this week on the BackTable podcast.
I think what you don't hear enough about is the small OBL, a tiny office OBL run by one person, with a few staff. I can tell you, I did this in Scottsdale and spent that Thursday and Friday for about a year and a half. And I had 3 FTEs with 2,500 square feet of space. If you can put that together, if you can finance your C-arm furniture, you get some computers and you're ready to go. Now, if you can do 4 cases a week, how many cases do you do a week in a hospital system, right? So it's a totally different way of thinking. If you can do 4 embolization cases a week, then you could take home $50,000 a month. If we can just talk real numbers here.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com.
This is Michael Barraza, returning as your host, recording from Baton Rouge, Louisiana. Today, we're going to be talking about genicular artery embolization, or GAE, and building a GAE practice in the outpatient setting. And it's an honor to welcome our guest, Dr. David Wood, to share his experience. Dr. Wood is an interventional radiologist and director of medical operations at Advantage IR. David, thank you for sharing your weekend and experience with us.
Thank you so much for having me.
You told me you're where today?
I am in Scottsdale. I'm in our Scottsdale clinic.
And do you spend most of your time in the Scottsdale area?
Yeah, we have a corporate office. Our company's corporate office is in Chandler. So I kind of go back and forth between our Scottsdale office and our Chandler office, and I live in north central Phoenix, so there's a little bit of driving around there, but it's not bad. Traffic situation in Phoenix is usually pretty good.
Not too bad. All right. Well, we've done a couple episodes before on GAE, and so I encourage our listeners to check them out. We did episode number 27 with Sonny Bagla and Ari Isaacson, and then episode 85 with Dr. Golzarian. But we recorded those in 2018 and 2020, and GAE looks different in 2022. We've got a lot more centers that are offering it, and we've got more and better data to support it. But your experience is pretty unique doing this in the OBL rather than an academic or other hospital-based setting, which is, where we first started to hear about these. And so I'm looking forward to hearing about that element of your practice. But before we do that, I'd like to talk a little bit about your practice itself. David, you spent, if I'm correct, 11 years as the chief of IR at a large medical center, Banner University Medical Center in Phoenix. Can you share your story of how and why you made the move to the outpatient setting and what that transition was like?
Absolutely. So I finished training in 2004, and I spent the following 13 years in 100% IR. I did 100% IR right out of fellowship. 11 of those years were spent at Banner. It was called Banner Good Samaritan Medical Center in Phoenix, turned into Banner University Medical Center when Banner Health acquired the University of Arizona health system. So I was there through that transition. It was kind of a collapse of the radiology group there that brought Kevin Hirsch and I in. Kevin Hirsch, IR stud, did med school and residency and fellowship together. We did all that at USC. And he recruited me to come join him to rebuild the radiology department. And we did 100% IR right from the start. So we already had inherited Y90 from Charlie Nutting, who had been at that hospital, but had left by the time I started there in 2006. Okay. And he had started us with TheraSphere and SurSphere there. And so we dove right into that and had a great time treating I think over 100, maybe 100 to 150 injections of Y90 a year, which, was a big volume for me and not something I had ever done before. So learned about that and kind of evolved to the point where we were selected to be the 3rd center of excellence for TheraSphere.
Wow.
MDS Nordion owned TheraSphere. Outside of Northwestern and Mount Sinai, we were the 3rd center of excellence, and it kind of served that purpose in the West for the company. And we did that for a few years up till 2017 was when I left. And I had kind of gotten restless, through those 11 years there at Banner University, knowing that, I was dealing with all the hospital inefficiencies that we're used to, striving to improve the patient experience and kind of just gain more like emotional ownership over the whole thing,
Totally.
the whole patient journey. And that was clear that wasn't going to happen in a hospital setting. We were hospital employees. We were we were Banner Health employees. We were not even part of a radiology group there. And so we really had no control over kind of the way the patients were treated. So the guys there, these IR studs, let me work half time, had a part-time 2 days a week, while I dabbled in what could I do outpatient. And there wasn't an instruction manual for that. I kind of went through some unsavory characters, met some bad people, like healthcare business people. Got involved with surgery centers. That didn't work. And ended up getting recruited by Modern Vascular.
Mm-hmm.
And I think I was one of Modern Vascular's first doctors besides Scott Brannon, and worked one of their first clinics in Mesa, Arizona, right next to Phoenix. And so pretty much all of the year 2018, I worked at Modern Vascular and learned PAD, learned CLI, pedal-plantar loop. Really hadn't done that at all. And it was really valuable experience. I learned from Scott Brannon kind of his pearls on doing those treatments. And I did hundreds and hundreds of cases there. Stayed just pretty much exactly one year. And the guy who recruited me to Modern Vascular, businessman, he left right after I started, and he and I had hit it off. And he went off and did some of his own things in the outpatient world, kind of in surgery centers. And then I left Modern Vascular after being there a year, and we were like, hey, let's see if we can make something else work. Let's see if we can take what we've, the best of what we've learned at Modern Vascular, leave out the worst of what Modern Vascular has, and form our own thing where we don't just treat PAD, but we also bring the best of our embolization technologies to an outpatient clinic, all under one roof. And
this was when?
So that was pretty much early 2019. And we spent the first part of 2019 opening a clinic in Austin. And, it took several months. So got that Austin clinic open in August of 2019. We had a non-compete with the Modern Vascular management, keeping us out of, keeping the CEO that I partnered with had a non-compete. So he could not be involved in IR in Arizona. I could. So we opened the Austin Advantage IR clinic. In the meantime, I opened my own OBL here in Scottsdale, the one I'm sitting in now. And I had to run that by myself. That could not be part of Advantage IR. It had to be arm's length. So I spent 3 days a week in Austin every week through maybe 6 months through 2019 and early 2020. And then I spent Thursdays and Fridays here in Scottsdale in my own OBL.
And so that was the beginning of Advantage IR?
That's how it started. Unfortunately, that time period you may recognize, early 2020, was the beginning of COVID.
Right.
Which was, a stressful time for everybody. We got through that. We certainly slowed down, got through that. In the meantime, we were making preparations to open another clinic in El Paso, Texas. And that clinic did open in
I read that.
February 2020, right when COVID stared.
Great timing.
Yeah. So some crazy times.
Starting an OBL from the ground up more challenging as it is.
Right. And we survived that time. The El Paso clinic actually just took off even with COVID. There's just such a need there. There's such a need in El Paso for healthcare. A lot of doctors in El Paso fly in. They just parachute in for a couple days a week and then leave and don't live there. And that's just an example of kind of how the healthcare system in El Paso is struggling. I think it's kind of that way for other border cities, just El Paso being one of the bigger ones. So that clinic did well even through COVID, and it continues to be our best performing clinic now.
Really? Advantage IR is not like all the other OBLs out there. You guys have a unique group of procedures that you guys are offering. It's not just legs and dialysis. What else are you guys doing?
Well, we actually don't do any dialysis, kind of because it's really regional. I'm sure you know the outpatient dialysis, fistula treatment, but in Arizona, it's completely owned by the nephrology groups, huge nephrology groups. And in Texas, it varies by city, but it's really hard to get those cases. So we just do our arterial procedures. I like arterial procedures. We do PAEs, UFEs, of course, PAD, so leg arteries, CLI, the whole thing, GAE, and frozen shoulder embolization, and hemorrhoid artery embolization. So I think that was 6. So those are the 6 arterial treatments that we offer. We will also do venous embolizations, varicocele, and pelvic congestion embolizations. So I really like embolizations. I really like arterial procedures. That's our focus. And I should mention that the non-compete ended in September of 2020. And so I took my OBL in Scottsdale and merged it in with Advantage IR. Mm-hmm. That's how the Scottsdale clinic joined Advantage IR.
Understood. Well, so what's the plan with Advantage IR moving forward? Do you guys plan to continue expansion?
Absolutely. Continue expanding. We're going to open a second OBL in Phoenix, in the west side of Phoenix, in a few months. That OBL is just being developed, being built out. In other cities, not sure. We're thinking about Omaha. We've gone through kind of a period of planning what we're going to do in the future, planning more like not just our 1 or 5 year approach, but our 30-year approach to where we're going to sit in healthcare. And maybe we can talk more about that later. But that's, so we've had a period of about 8 months where we haven't opened or even made strides to open a new OBL in a new city. But I think we're starting a new growth phase now and just figuring out what city that's going to be.
Okay. David, a lot of our listeners are trainees who are going to be looking for jobs soon or are currently looking for jobs. And I was wondering if you have any advice for those that are hoping to either begin their careers or transition into the outpatient setting. Like, how should they go about looking for a position in a practice that looks like yours?
I would actually, I'd love to talk to someone about joining us, but I would also encourage young IR docs to think about opening their own. You would be surprised how lean you can make these places. We all we go to conferences and hear about the big OBLs that are super busy, have lots of doctors working them, lots of staff, maybe multiple locations. But I think what you don't hear enough about is the small OBL, a tiny office OBL run by one person, with a few staff. So I can tell you, I did this in Scottsdale and spent that Thursday and Friday for about a year and a half. I spent every Thursday and Friday in my Scottsdale clinic. And I can tell you that with 3 employees, I had 3 FTEs with 2,500 square feet of space. And if you can put that together, if you can finance your C-arm and do 4 cases a week. So imagine that. So imagine 3 FTEs. It's a doctor's office. It's not an ASC. This is easy stuff to open. You could just find space to lease. I did it with 2,500 square feet. I had 4 consult rooms. I had a procedure room that was 16 by 20. I have 4 recovery bays and a C-arm. You get some supplies, you get some furniture, you get some computers, and you're ready to go. Now, if you can do 4 cases a week, and imagine that, how many cases do you do a week in a hospital system, right? So it's a totally different way of thinking. If you can do 4 embolization cases a week, then you could take home $50,000 a month. If we can just talk real numbers here. Yeah. I think people should know these numbers because I think that that secret's getting out there that embolizations pay really well in offices, and insurance companies love that. They want these things done in your office,
absolutely,
your independent IR doc office, because that is the cheapest place that these treatments can get done, for Medicare or for commercial insurance companies. And yet it's quite a windfall for an independent IR doc who's working solo. So you can you can get 100,000 in revenue. You could count on 100,000 in revenue per month, and the expenses could be about 50,000 a month. So you could take home 50,000 a month for working 2 days a week. Consults on Thursday,
Incredible.
procedures on Friday. And so that works out to 600,000 a year. And if you consider the salary for an IR doc working 2 days a week, let's say 5 days a week is 500,000, right? So let's say 200,000, you're bringing home 600,000, 200,000 of that is market salary. So there's 400,000 of profit there for just 2 days a week of work. The catch is, can you get 4 cases a week? And that's actually not that easy. You have to make sure that you can do that. So I would encourage trainee IR docs to get a start in a community. You really have to know people in your community. You got to get to know doctors. My wife's an OBGYN. That definitely, she trained at Banner University residency for OBGYN, and then she stayed there, and she's one of the attendings there now. So yeah, that has helped me get to know OBGYNs in my community. A lot of them stay, a lot of those residents stay. That's what you do. You make relationships, you make partnerships where you can, and you do good work. And if it's a big city like Phoenix is, then yeah, you could get even 4 UFEs a week. I was getting a combination of UFEs and pelvic congestion embolizations at that time. And that probably made up almost all of my cases. And I was not doing 4 days a week every week. There were weeks I did 1 case a week, and there were weeks that I did 5 or 6. I don't think I could say that I averaged 4 cases a week, but someone who could actually do really well working 2 days a week and expand into the other days. Sure. You could expand into those other 3 days, or you could do something else those other 3 days of the week. Or you could just do nothing and have the greatest job in the world, right? I think that trainees need to know that it's actually not out of their reach. I think that they should work a few years in a community, get mentored by a group of IR docs, and then think about taking the plunge if they were so inclined. If you had that kind of risk tolerance and that seemed like an attractive thing to do with your career. It's a little risky, but look what you have to fall back on. You're a radiologist.
Right. It does make a lot of sense though to, work for a few years in a community and then consider, going to the outpatient setting in that community where you have those connections, those partnerships, as you mentioned. I would imagine it's harder to start this in a brand new city where you don't know any of the other physicians.
I think that would be really hard. Yeah, it's doable. But, you don't want to, if you're starting your own practice, you really don't have a marketing budget. You can't hire a liaison to go visit.
Sure.
Maybe you can, but it would be tough. I think that you could start your own OBL with 100,000 in cash. The initial McKesson order is just eye popping. If you take bare shelves and fill it with all the stuff you need from McKesson, that by itself is probably 50,000. You can't really finance that. You can finance everything else. You can finance the furniture, the computers, the C-arm, the gurneys, the exam tables, the chairs and desks. So you do need some cash, and you do need some relationships. You need to know that you're going to hit the ground running a little bit.
That's a great answer to that question. And I think that gives us some good background to start talking about GAE and the OBL. So first of all, why GAE? What makes this a good procedure to do in the OBL?
What's really attractive about GAEs to me is that they're actually technically pretty easy procedures. Yeah. I don't want to minimize it. It's a procedure. It's an arterial procedure. But if you started out tackling prostate artery embolizations, which to me I think are technically pretty difficult. They can be, right? So, and I tackled that. I think we all have come to a time where we tackle PAEs, and if you're working in OBL, you gotta do PAEs, and so when you go from a PAE, after PAEs kind of predated GAEs by a few years. So then when you when you're thinking about GAE, it's a lot more straightforward. The anatomy, you can usually get a case thoroughly treated and done in 45 minutes. It's very easy for patients to go through the treatment. You could do it with very little sedation or even no sedation, discharge right away. And probably the beautiful thing is that there's very little side effect.
Yeah.
And very little complications. So, the risk, the therapeutic window, is a good term for that. It's a wide therapeutic window when you're talking about GAEs because the risk is actually very, very low. And the upside is very high. So for technical reasons, you can get a patient in and out. You don't have a long recovery. The UFI recoveries are a little longer for me anyway. And just in every way, you don't need advanced imaging. You could do GAEs with a pretty basic vascular package on a mobile C-arm, no problem. You don't need, there's no question about needing cone beam CT when it comes to GAEs.
Yeah, I hadn't thought about that, about, the advantage of this being, a low likelihood of complications. You compare it to doing, say, iliac artery recanalization. I mean, that could be scary. You can occasionally get a rupture. Yeah. You're not going to get anything like that in a GAE. You're just going to get down there, go in around the knee to your embolization, and that's it.
It's a beautiful procedure. And the frozen shoulder embolizations takes a little longer.
Okay.
It can be a little more tedious, but for those reasons, you could, I just imagine if GAE takes off and it becomes a really commonly done procedure, it's the kind of thing that you could do many a day. Like you could do
totally
many GAEs in a day. So it's really kind of staggering to think about the future that GAE could have. It's just,
I agree.
The size, the size of the market.
Absolutely. And not only the size of the market, you compare it to UAE or PAE, you're not really, you're not offering really a competing therapy, in my opinion, I mean, you're not, this isn't an alternative. It's like UAE is an alternative to hysterectomy. You're helping a challenging patient population. And this is not something that I think that we would be fighting with, orthopedics or PM&R or, pain management. I think this would be, these people would be very pleased to send these patients to get a therapy that's going to work.
Yeah. And that's also why patients are running at it. That's the key of GAE is similar to PAE in a few respects. One, these are what make treatments great for OBLs. One, patients know the name of their disease. You can't say that about everything we do.
Totally.
But patients do know that they have arthritis in the knee. So it's similar. So I'm going to name three things, and they're true about PAE as well. So so they know the name of their disease. Two, it's a very common disease. And three, patients have declined treatments that have been offered to them. And so you have a cohort of patients that number in the millions who know their disease, they're suffering from it every day, and yet they've declined what they've been offered. So they're continuing to suffer untreated. You could say that about PAE as well. But that's, that makes when you look at it that way, that kind of shows how staggering the GAE volume could be.
Absolutely.
Worldwide. Patients are running at this. They really need this. Most of the patients we see, and especially in El Paso, are suffering. We just looked at all of our GAE data. We had done 220 GAEs in the year 2021.
Wow.
And we looked at and I think half of those are in El Paso.
No kidding.
And we looked at our median VAS score. It's 9. Our median VAS is 9, which means you have just as many 10s, right? If I'm doing this right, you have just as many 10s as you have less than 9s.
Right.
So you have just as many 10s as you have 5 through 8s, because we wouldn't do it for below 5. So that just is an example of the scope of the problem and how patients are just desperate for something that'll work.
So once you decided to take this on, how did you promote or market the procedure? Or basically, what did you do to start getting patients in the door for this?
Really, we always market to doctors' offices. We have liaisons who do that. But I can tell you that's one thing that doesn't work that well. This sounds crazy to doctors. Honestly, if you go to a doctor and tell them you're going to slow down or stop the blood flow into the knee joint to treat arthritis pain, they look at you probably like a lot of us IR docs kind of thought about it too. It just sounds crazy. And why could that be a thing? So it takes a while to get PCPs to adapt this as in their treatment, in their management strategy.
Yes, I've had that same experience. I gave a talk to a PCP office like 2 weeks ago on this. I'm like, what are you talking about?
Yeah.
No one had ever heard of it.
Yeah. You could actually have more luck with NPs and PAs than with doctors, family doctors, for example. But we've had the most success just marketing direct to patients. So really, I think we end up treating about a quarter of our leads. So to do 200 procedures, we need to get 800 leads. I'm talking in a year, like in the year 2021, we did 200 procedures, took 800 leads to get there, maybe 800 to 900. The most successful way we got leads direct to patient was TV commercials. We actually had TV commercials in English and in Spanish. And they did really well, especially the Spanish language commercials that we had on TV. I think that half of our self-referred patients were from TV commercials.
Okay. What proportion of self-referred patients would you say you're getting like relative to the ones that are referred?
Oh, it's like 10 to 1.
Oh, wow.
Yeah, it's a huge difference. Yeah, we didn't get that many referrals. We tried, but I think we probably, per quarter, I'm thinking about it in terms of like quarterly numbers. It's probably about 200 digital leads, marketing leads versus 20 or so physician referrals in a quarter.
And the physician referrals, are they coming from PCPs primarily?
Yes. I think PCPs are the highest yield referring doc when it comes to GAEs. So you may wonder about orthopedic surgeons or maybe even sports medicine docs. Sports medicine docs are open to it, but they have some competing interests of their own.
Right.
If they're doing injections, and you can get a sports medicine doc to consider GAE if their treatments are just failing, and a patient is not willing to consider going to an orthopedic surgeon. Orthopedic surgeons, I have had orthopedic surgeons send GAEs, and I'm not sure how we were that lucky. I actually haven't met him. So it's just one orthopedic surgeon I'm thinking of. And I know that
same with me.
Yeah.
I've only done 2 of them, and then they both came from ortho.
Awesome. Yeah. So, and there you go. I think that says a lot that orthopedic surgeons are kind of adapting it as a legitimate treatment. Because I think we have a lot of shyness about that. They have competing interests. Are they going to think that it'll ruin their surgery, or their wounds won't heal, if they do end up doing surgery. So we should probably be more aggressive marketing to orthopedic surgeons. And we just haven't yet. I think that might be a good pivot to take. How did you get those? How did you get those surgeons?
I just got a phone call for the first one. It was an orthopedic surgeon that I knew. And he, I guess, had read about it and asked me if it was something that we offered. And this is when I was still in Nashville. It's like, yeah.
He had read about it.
We certainly can. Yeah.
Wonder where he was reading about it.
The other one was the second one was admittedly for hemarthrosis.
Okay.
And so it was post-prosthetic hemarthrosis. And so he called and asked, like, hey, I've heard that this might work. And we did it.
Awesome. And so it worked. It worked for the hemarthrosis, I'm sure. And
yeah, it did.
And maybe did they have osteoarthritis?
The other one I have not seen because I moved like not long after.
Right. Okay.
I think he got a good result, but I didn't see him again. So once you got started doing these, how did you manage to, sustain or increase your referrals? Did you do anything different or just, repeat the commercials, more phone calls?
Just, we kept the commercials going. We saw that we found something that was resonating well with patients. And so we kept going. I can probably tell you some interesting stats about, our marketing spend. I can't tell you. So our second most successful marketing channel was just web search.
Yeah.
We did newspaper ads. We did radio ads. Those were not as fruitful in absolute numbers. Now, what is probably more important is like dollars per lead, dollars spent on the marketing per lead. I don't have good numbers on that, but our company is trying to get it together to the point where we can kind of nail that down to a granular level. But I can say that overall, we had to spend about $2,500 per procedure.
Sure.
So to obtain that lead, and see it through to procedure, ended up costing about $2,500 in marketing, which sounds pretty steep, but still, when it comes to embolizations, it's still arterial embolization still leaves plenty of room for a profit margin.
Let's move ahead and talk for a second about your experience evaluating and treating these patients. So let's say you've got a full schedule of patients in your clinic that are seeking relief from knee pain. How do you go about identifying the ones who are likely to benefit from GAE?
So we've evolved a little bit in this. There was a point where the only U.S. study was that study done by Sonny Baglet and Ari Isaacson. And they had relied on the point of maximal tenderness. So they had decided to treat medial or lateral, but not both, and depending on which of those sites was most tender. And so we were doing the same thing. And if someone didn't have tenderness, we would let ourselves be guided by where their pain was maximal, whether it was medial or lateral. But we would base the treatment decision on pain and pain at least 5 out of 10, so 5 or worse out of 10. And we need to see osteoarthritis on an X-ray.
Yeah.
We started out requiring an MRI before we would, as part of our patient selection and patient workup. Stop doing that. That article came out around in 2021 about the MR predictors of success or failure and GAE outcomes. And it made a pretty strong case for X-ray being good enough, a good enough evaluation. You want to see that they have osteoarthritis, that they don't have some other cause of the pain, or that it is not a normal X-ray. But there's probably not important soft tissue information that you would need an MRI to tell you, in order to select a patient being a good candidate or not for the procedure. So we started just relying on X-ray. That paper was surprising in that it did not show that synovitis, this has always been about synovitis and embolizing angiogenesis and synovitis, but that paper did not show that synovitis was a predictor of a good outcome. It actually showed the opposite. So I don't think we have the whole story on the role of synovitis. And we know that the procedure can work if there's no synovitis. On the other hand, if there's a synovitis with effusion, that was actually a predictor of a poor outcome in that paper. So for now, I think I'm convinced that an X-ray is a good enough workup along with a patient who has moderate to severe pain.
In addition to, people who don't fall the right spot on the pain scale or have negative X-rays, is there anything else in a patient that, might suggest that he or she is not a good candidate for GAE?
Well, we don't treat people who have had surgery. So if they've had a total knee. Now, I think that there could come along a patient that would be a good candidate for that. And by a good candidate, I mean someone that you're willing to take a chance on.
Yeah.
Because it's not studied and we don't know. There is some anecdotal suggestion that it might help, coming from Dr. Okino in Japan. But we really don't know. Now, if a patient came along that was just desperate for something and had tried everything and was in a lot of pain, then I would try it. But so far haven't done it. Anything else? I can't think of I can't think of anything else.
So, a lot of these patients are going to be old, and presumably you're going to run into some who either have look, let's say you look at your x-rays in the knee and you see just like a ton of calcification in the distal SFA and the popliteal artery. Do you ever run into that where you see a patient with terrible knee pain, but also has, symptoms of significant PAD or imaging findings that would suggest there are going to be at least some stenoses, if not some CTOs on your way down?
That actually hasn't happened yet. We haven't. I know that my partners and I have not come across a patient.
I'm surprised.
Like I know, isn't that is a surprise. I think that we would, we ask about symptoms of PAD. Yes, of course, they could be asymptomatic. They could have severe PAD and be asymptomatic. So we would do our best with physical exam to figure that out ahead of time. If there was a suggestion of PAD, even if asymptomatic, we just wouldn't do it. We wouldn't want to take the chance on putting that patient in jeopardy.
Sure.
When it comes to their perfusion. I can't say that it has happened. So I would say that would be rare from my experience. I think that would be rare. You should ask about PAD symptoms and you should feel their pulses. And if there's any doubt, then probe further, get a duplex, see what's going on there.
So look, the workup for this or any procedure, of course, needs to include the determination of how they're going to pay for it. And I'm curious what your experience has been like, with insurance coverage for this procedure.
It's been pretty good, actually. Most commercial insurance companies will say that CPT code 37243, the arterial embolization code, is NAR. We get the NAR, which is no auth required. And, there may be a blessing there in the fact that 37243 is used for all kinds of embolizations all over the body, in that we have, when no auth is required by an insurance company, they will usually pay the claim.
Yeah.
Now, there are insurance companies who insist on getting a pre-authorization first, and even Medicare Advantage plans. So some commercial insurances and Medicare Advantage plans will do a pre-authorization. And I can tell you the opposite is true for that. When we request a pre-authorization, it's usually denied when it comes to GAE. And so we haven't been fighting those or appealing those so far. That we may be coming to the point where we should start appealing those, because I think there's a growing body of evidence that we could make the case that it is not only becoming, would we say it's standard of care yet? Maybe not. It's still a pretty cutting edge treatment.
Sure.
But it's better than anything else out there. And I think that anybody, including insurance companies, would agree that it's better than the injections, the viscosup injections that they are paying, and it's worth keeping a patient out of a total knee, for as long as possible. So I think that the industry will come to the point where we'll be making that case and successfully. But I think we're in kind of a weird time right now, where it's new. And to those reviewers who are doing your pre-auth, it's probably the first time they've seen this kind of thing requested. And we usually get denials of those.
Yeah. It seems about like where PAE was a few years ago.
Yeah.
And so hopefully it starts to follow the same course and shows similar efficacy. But, I'm confident that this is going to be a big thing for us. I hope, at least. So David, tell me how you set expectations with these patients in, what you think they'll experience in terms of pain relief.
That's a tough one, because the success rate is not 100%. It's not even 90. It's not even 80. The UCLA paper had a really high threshold for success. WOMAC improvement by 50% and at 12 months. So high threshold, but so their success, I think at a 25% improvement of WOMAC. I think it was 85%. So it depends on how much you want the WOMAC to go down or you want symptoms to improve. But if you look at, I guess, what do you want to know if you're a patient? You want to know that your pain is going to get better. like a lot
Right.
better, that your life's not going to be ruled by pain anymore, that you're not going to be kept up at night by pain, and that you're going to be able to do the activities that you want to do. Maybe even more exercise. It's critical for some patients. Many patients with arthritis also have issues with their weight, and it's critical to relieve pain in their knees so they can exercise, and they want to. They just can't because it hurts so much. So what we need to do. So I tell patients that I don't get into what percent is your WOMAC going to improve. I tell patients that the chance of you having significant major improvement in your pain is 70%. The UCLA study was 68%. I think that probably is true. A patient can get partial relief more often, higher success rate, getting partial relief. It could be 85%, but really massive sustained relief of pain is about 70%. That's not that exciting.
That's pretty good.
Is that pretty good?
I think it's pretty good for patients with severe pain, severe knee pain. And this is a minimally invasive procedure to treat it. I mean, I think, what are you going to get from a PRP injection? What's their rate of, significant pain relief? I bet it's not 70.
I'm sure you're right. I'm sure it's the best thing that's out there right now, short of a huge surgery.
Yeah. And so the way I look at it is that, let's compare it to a total knee arthroplasty. That is probably going to help with their pain, but it's a much more morbid procedure. If there's a possibility that something that is less invasive is going to work, it's not a home run. It's not 100% that it's going to get better. But if there's a chance you can get that pain taken care of without a hospital stay, then I think for a lot of people, that's worth a shot. Even with the 30% chance you're not going to get total pain relief.
I think most patients agree. Most patients hear 70%. They go, no problem. That sounds great. But, I'm used to UFEs. In IR, we're used to kind of more of a sure thing, right? We're used to UFEs or even PAEs. Pretty high, really high success rates. Yeah. So, you will find yourself sitting across from a patient who won't feel like it did anything for them when it comes down to it. But on the other hand, 70% is good. It's a lot of patients. And when it works, it really works. And it works for a long time. It'll work for way more than a year when it does work.
Wow.
I had one patient, can I tell you about?
Please.
Early days. This is the best kind of patient. So it was the early days I was doing it. And I think I said we did GAEs for pretty much since January of 2021 is when we started them. But I actually had done a few in December of 2020. So there was a woman who came to me. She's in a wheelchair. She had some kind of neuropathy that affected motor nerves. And so she was not able to walk. She had osteoarthritis in her knee and had tremendous pain. She's not weight bearing, and yet she had this pain that would just gnaw at her and keep her up at night. And so we did, and she was never going to have surgery given her comorbidities.
Right. So
she was desperate for something, and I treated her in late December, and I got a call on Christmas morning from a patient. And I'm sure you agree that when you get a call from a patient on a holiday or a weekend day, it's never good.
I'm
right?
nervous.
It's never good news though if they're calling. Well, it was a Christmas miracle. So she called to tell me that she had a Christmas miracle. She woke up Christmas morning with no pain.
That's incredible.
And that was huge. That's just an example of the kind of patient that I like to treat. There are millions of elderly patients who are in a tremendous pain from arthritis, who are never going to have surgery and have nothing else. And this is the thing, because it's you can treat a very frail elderly person very safely and highly effective.
No, that's why I really like procedures for pain, like vertebral augmentation. I mean, you can really cause like a dramatic improvement in a patient's quality of life with something like this. And it's certainly, exciting prospect moving forward, as you said, with the potential volume of this. In terms of actually doing them, I think we can skip over a lot of the technical details that are out there, but I do have a few questions. And my first one, and the answer may be no, but are there any real differences in terms of treating these patients for GAE and the OBL compared to the hospital, in terms of technique, equipment, or anything else?
I think just that it's simple. It's a lot simpler. You really don't need, I guess it's a little controversial. It's not to me, but whether you can do a PAE without cone beam CT. And a lot of the thought leaders will say, well, at least to start, you should do your first 40 or your first 50 with cone beam CT, or, you hear things like that. No question, that is not the case for GAE. You could use a pretty simple C-arm. I think as long as you can do DSA, you really need DSA, but if you have a mobile C-arm that can do DSA and an OBL, that's all you need. So I think that's true of all the musculoskeletal embolizations that I think we know, or it's looking like that's going to be a huge part of our career, are these musculoskeletal embolizations. And Achilles tendon, tennis elbow are all things that are next. I think, can you imagine how our days are going to look? And these are very enjoyable cases. They're simple.
Super fun.
Yeah, right?
They're fun. They're small arteries. You get into them. And we do a lot of bone tumor embolizations where I am, for renal cell mets. And it'll be in the arm and the leg, the knee. And they are so fun. I love them.
Yes, they are. They're really rewarding. They're personally rewarding to see that blush, and to make that blush disappear. Totally. And yet you want to kind of like minimize, you want to whisper, you want to minimize your footprint. So you want to make that blush go away, but you want to leave the arteries open and kind of leave everything else untouched. And I find that really rewarding, and it's simple. So you could do a lot of these every day and help a lot of people, and keep your clinic's throughput efficient, which is huge.
And I think that's an important point about doing this in the OBL. One of the arguments, I work in a hospital setting, but one of the arguments that's been made to me on this podcast and elsewhere is that for a procedure like this, where it's usually pretty straightforward, it is a much smoother and faster and more comfortable patient experience. Has that been your experience?
Yes. Patients are surprised. They're always surprised how quick and easy it was. And usually the huge smiles when they roll out, and it's even too early to know if it worked, but totally. You can really brighten someone's day by staying on time, and having nice people. Our motto is kindness and accountability. Mm-hmm. Everybody has to be their kindest self to patients and brighten everybody's day. And we've got a great team for getting that done. And patients are always surprised how easy the treatment was and how much they liked the people that they went through it with here in our team.
When you're doing this, just a couple technical questions. Do you embolize, both sides of the knee? How many arteries are you treating, and what are you using for your embolic agent?
That's another thing that's evolved a little bit for us. So I talked to our results were actually a little bit lackluster, and we were continuing to do that treatment strategy that I described, where we only treat medial or lateral, depending on where the most tenderness was. And the thought leaders now are being more aggressive. Even the UCLA study treated anywhere there was pain. So they would treat medial and lateral. If there was pain, medial and lateral. If there was tenderness, medial and lateral, or even if the patient just said there was pain on the inside and the outside, then they would treat medial and lateral. And it looks like that's what needs to be done. So actually, I talked to someone recently who said that he treats anywhere there's angiogenesis, no matter what, no matter where their pain is, no matter where they say their pain is, and no matter where they're most tender, treat all the angiogenesis. And we've just started doing that. So that's probably going to result in more side effects a little more pain for probably up to a week, at least a few days of more pain as a side effect of the procedure. But it's looking like that will make the procedure more effective.
Anything else, any pearls, pitfalls you've picked up and, getting a couple hundred of these under your belt that you've noticed to either, optimize clinical improvement or prevent complications?
Well, the ice pack, I think everybody knows about the ice pack. We do an ice pack in everybody. We haven't seen those 220 patients. We didn't have any skin erosions or ulcerations. We did have one patient. I still don't know what happened to him. It might have been fat necrosis, but he developed a very inflamed, red, and tender, firm nodule in the subcutaneous tissue around the knee. I don't know, kind of around the upper calf or lower thigh. And so a hard nodule that was tender and also really red skin. And it was painful for him. It was not a normal side effect. I don't know what it was. He actually got admitted and treated for cellulitis. I'm not convinced that it was true, like bacterial cellulitis, but I guess it's possible. But that was the only one. Other than that, we did not have any, and he didn't develop any ulceration. It was just what I described, the firm tender nodule. And so we haven't had any like ulcerations or anything like that. We do get the bruise. I like to do I heard that Dr. Okino will let the microcatheter peek out of the tip of a 5 French catheter or maybe even like a 4 French catheter. So I'll do that without a wire. I'll just probe along and find with puffing and find vessels that way. Sometimes you need a wire, but you can do a lot of this without a wire, especially the directions. I like using directions. I like using a burn tip. I like that you can turn the tip, that it really does have that one-to-one torqueability. So I'm pretty attached to
That's a great catheter.
The direction, right? You can just kind of advance it and turn it. I think that when I think about what the future is going to hold for how this is going to be done, I think the key is going to be pharmacologics, right? Being able to inject, being able to give a drug into the synovium through their feeding arteries is a powerful paradigm, powerful strategy. And it's just a matter of what that pharmacologic is going to be, because we know that we can load drugs onto microspheres and then we can bring about the slow release of those drugs into the synovium. And so what's the right thing going to be? It's going to be some kind of a receptor blocker. That there's a lot known about the biochemistry of the signal transduction and the initiation of inflammation and the persistence of inflammation. That's really well known now. And, that knowledge is increasing every year. But I think that the industry is close to trying pharmacologics along with our microsphere embolization and, influence the physiology of that osteoarthritis, on a biochemical level. So I'm excited about that. I know that's got to be coming. And as far as what is going to stop that cycle, halt that cycle of cartilage destruction and inflammation, I hope that embolization has a role in that long term. I know that pills are being investigated for that purpose. And so far, there's nothing that's been successful at influencing that cycle. I'm hoping that embolization or even drug-eluting bead embolization will be part of that.
So after treating these patients, when do you see them back in clinic?
We do 1 month. We do kind of like studies, 1 month, 3 months, 6 months. We follow the WOMAC. So, I would like to see, we kind of do patient selection and patient follow-up the same way studies did it. We want to reproduce the UCLA study was just so good. We just want to reproduce their patient selection, their techniques, and hopefully get their results. Their results were really good. They got, I think, an average WOMAC decrease of about 28, if I remember right. And that would be really good. That would be tremendous for a patient. We were getting more like 20. I'll tell you, I'll take a vulnerable moment and tell you that we were getting more like a 20-point improvement doing it the kind of the more conservative early technique. So hopefully we'll get better results with our new strategy. But 1 month and 3 months, patients usually are doing better at 3 months versus 1 month, and then they kind of level off from there. And it's hard for us to get patients to keep coming after 3 months. We try to get them in for a 6 month, but you know how it is. They just stop calling. They stop returning our calls.
Especially if it worked.
Yeah.
It's like, my pain's better. I'm done.
Yeah,
I'm done
if
here.
it worked, or it didn't work, and they went on to something else.
Right. Have you ever done any retreatments for patients who either have residual or recurrent pain?
We have, when I would offer that if I thought there was something technically incomplete about my treatment.
Sure.
And so when we were treating only medial or only lateral, and a patient had lackluster results, we would offer to do it again and treat that other compartment. Actually, not that many patients took us up on that. But I guess what I would do also for that kind of patient is, if I didn't think that a repeat treatment would bring about a better result, I think I would just make sure that their conservative strategies were being optimized. It usually isn't, honestly. What's it called? The Orthopedic Surgery Society. I forgot what it's called, but OAS or something like that. Their guidelines, their management guidelines just came out at the end of the year. And it seems like the best things for these patients are just education, structured exercise, maybe even a little bit of physical therapy, but maybe just as important is just kind of a guided exercise program that they keep up with, along with education, can actually prevent a lot of total knee replacements if all that is just optimized. And patients really don't get that, in a really aggressive way that the doctor and the patient is consistent about and dedicated to adopting. So I try to encourage the patient to follow those things and to get to a physical therapist that I know can teach them those things. I'm also considering genicular nerve ablation. I just read the paper that compared GAE with genicular nerve ablation and visco or injections, visco-sup and steroid injections. And the ablation patients in that meta-analysis actually did pretty well. And so I've always, I assume that it has success rate and recurrence issues. And I think that our treatment is probably better in those regards, as far as recurrence goes, but ablation may be a good second choice as well if GAE didn't work.
Yeah. Well, that's really about all I've got. One more question I have is wondering if you have any advice to any physicians in the outpatient setting out there who are interested in starting GAE in their practice.
I think it's important to remember that this is a doctor's office. And this is that office that like your old GP, used to work in, the doctor down the street that just hung a shingle. These procedures can be done in that same kind of office, these treatments. And yet you could just get some supplies, get some equipment, get a few people, and you could be doing these and collecting a tremendous reimbursement for them. And the insurance companies are happy to give it to you because it's the cheapest way to get these patients treated.
Right.
So that's really powerful. That's a big deal. I think this is probably the highest reimbursing 45 minutes in a doctor's office, right? Is there anything else that reimburses better in 45 minutes in a doctor's office? I guess if you consider like the pre-op and the recovery, you could, call it 2 or 3 hours, but still I don't think there's anything like this. And that makes it a huge opportunity for us.
Yeah.
But it also kind of makes it a target. Who controls the office now? Who controls doctors' offices now? 70% of doctors, like primary care doctors, work for a big hospital system now. Their practices have been acquired. There's been a huge run of acquisitions in that area where hospitals and private equity companies are buying doctors' offices. And they control the office. And who do you know that they have CFOs and accountants that are looking at this stuff. What do you think they're going to do when they hear that they can get $10,000 for 45 minutes of work by doing arterial embolizations in a doctor's office? You don't even need an ASC to do these. They haven't yet, but that's going to get somebody's attention. And their consultants at some point there, when they go to their conferences, these hospital people are going to go to conferences and their consultants are going to be telling them, hey, you have all these doctors, you have 1,000 doctors in your network, you have hundreds of thousands of patients. This is something you should do and keep it. Don't refer it out. Keep it in the network. So I think people who want to start a GAE practice, I think that it's important to plan for how you're going to fit in to the healthcare paradigm that's coming, the healthcare paradigm of huge hospital consolidated networks owning doctors' offices. And how are we going to fit in? That doctor who you may have relied upon to be loyal to you and send you patients may not always be able to if they've been acquired and they're having hospital people tell them where they can or can't send patients and just keep patients in the network. And when hospitals start doing this, they're going to mess it up. They're going to ruin it when hospitals control it, versus what you and I can do as independent doctors. What hospitals the prices are going to go up. They have higher contracted rates. Patients are going to wait a long time. People are going to be mean to them. And then it's all going to just get kind of messed up. So I think that's a shame. That's a shame. But I think more to answer your question, we all need to think about where we're going to fit into that, and it's not just a matter of doing good work. That's crucial, of course, doing good work, making patients happy, making doctors happy, but it's also about making partnerships, friendships and partnerships and loyal partnerships, and sometimes even financial or business partnerships, to kind of stake your place in that network dominated paradigm. And so I guess that I would leave it at that. I don't have the answer to what the best way is to ensure that we'll all have a place, in introducing GAE to an OBL practice. But that's certainly a major consideration for all of us.
Absolutely. This has been very enlightening. Thank you very much for sharing your Saturday and your perspective with us. That's about all I got.
Awesome. Well, thank you. You're welcome. And thank you. Have a good day.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang. Administrative support provided by Jinwoo Kennebrew.
Thanks again, and see you next time.